The bronchial tree includes the right and left bronchi, secondary bronchi, and bronchioles. When the mucous membranes lining the bronchial tree become irritated and inflamed, excessive mucus is produced. The result is congested airways. Acute bronchitis is usually an isolated episode caused by a virus. If bronchitis occurs more than 3 months out of the year for 2 consecutive years, chronic bronchitis is diagnosed. See the discussion of chronic bronchitis later in this chapter for more information that applies to both the acute and chronic forms. Acute bronchitis is an inflammation of the bronchial tree. The bronchial tree includes the right and left bronchi, secondary bronchi, and bronchioles. When the mucous membranes lining the bronchial tree become irritated and inflamed, excessive mucus is produced. The result is congested airways. Acute bronchitis is usually an isolated episode caused by a virus. If bronchitis occurs more than 3 months out of the year for 2 consecutive years, chronic bronchitis is diagnosed. See the discussion of chronic bronchitis later in this chapter for more information that applies to both the acute and chronic forms. Bronchiectasis is a dilation of the bronchial airways, Fig. 31.1. The dilated areas become flabby and scarred. Bronchiectasis can remain localized or spread throughout the lungs. Secretions pool in these areas and are difficult to cough up. This creates an environment where bacteria can flourish and infection is common. Bronchiectasis is a dilation of the bronchial airways, Fig. 31.1. The dilated areas become flabby and scarred. Bronchiectasis can remain localized or spread throughout the lungs. Secretions pool in these areas and are difficult to cough up. This creates an environment where bacteria can flourish and infection is common. Signs and symptoms: the patient with bronchiectasis experiences recurrent lower respiratory infections. Sputum is copious and purulent. The accompanying cough can produce as much as 200 millims of thick, foul-smelling sputum in a single episode of coughing. Extreme airway inflammation may cause sputum to be bloody. If bronchiectasis is widespread throughout the lungs, the patient may experience dyspnea even with minimal exertion. Wheezes and crackles may be auscultated. Fever is present during active infection. Cor pulmonale, right-sided heart failure, covered in Chapter 26, and clubbing of the fingers may develop with chronic disease. Diagnostic tests: a chest X-ray examination is done, but it may not show early disease. A computed tomography (CT) scan provides a better view of the dilated airways. Bronchoscopy may be done if needed. Sputum cultures determine infecting organisms and guide antibiotic therapy. Additional testing may be done to determine the cause of bronchiectasis. Therapeutic measures treatment is aimed at keeping the airways clear of secretions, controlling infection, and correcting the underlying problem if possible. Antibiotics may be used intermittently or for prolonged periods. Azithromycin, Zithromax, may reduce exacerbations, acute worsening of symptoms. Measures to prevent infection, including vaccinations for flu and pneumonia, should be implemented. Bronchodilators relax smooth muscle in the airways to reduce obstruction. Mucolytic agents and expectorants help loosen and mobilize secretions so they can be coughed up. Bronchitol, a form of mannitol, is an inhaled mucolytic that promotes mucus clearance. It is a sugar that draws fluid into the airways to help liquefy mucus. Anti-inflammatory agents such as corticosteroids or leukotriene inhibitors reduce airway inflammation. Chest physiotherapy, CPT, or a high-frequency chest wall oscillation vest can help mobilize secretions. Non-invasive positive pressure ventilation, NIPPV, see Chapter 29, can help maintain oxygenation. Oxygen is used if hypoxemia is present. Oral fluids are encouraged. If the affected area of the lung is localized and symptoms are severe, surgery may be considered to remove the diseased area. Lung transplant may be considered in severe cases. Nursing care tip: if your patient is coughing up a lot of sputum, line an emesis basin with a white tissue. This makes it easier to assess the color of the sputum and simplifies cleaning out the basin. Pneumonia is the cause of many hospital admissions each year and is a common cause of death from infection. Persons at risk for pneumonia are the very young, adults over age 65, smokers, those with chronic disease, and people with compromised immune systems, such as those with AIDS, alcoholism, or who take medications that reduce immune function. Pneumonia is categorized according to where it is acquired. For example, hospital-acquired pneumonia, HAP, is defined as pneumonia that develops at least 48 hours after a hospital admission. One type of HAP is ventilator-associated pneumonia, VAP. Healthcare-associated pneumonia, HCAP, is pneumonia that develops in a person who has had recent healthcare encounters such as a recent hospitalization, residency in a skilled care facility, home infusion or wound care, or chronic dialysis, as well as a family member with multiple drug-resistant organism. Risk factors for HAP include older age, intubation, chronic lung conditions, depressed consciousness, and aspiration. Community-acquired pneumonia, CAP, develops in the community and is usually less serious than other forms. Each type of pneumonia may be caused by different organisms. Pathophysiology pneumonia is an acute inflammation and/or infection of the lungs that occurs when an infectious agent enters and multiplies in the lungs of a susceptible person. Infectious particles can be transmitted by the cough of an infected individual, from contaminated respiratory therapy equipment, from infections in other parts of the body, or from aspiration of bacteria from the mouth, pharynx, or stomach. Organisms from the mouth and pharynx may be related to poor oral hygiene or may be present because of a cold or influenza virus. When pathogens enter the body of a healthy person, normal respiratory defense mechanisms and the immune system prevent the development of infection. In a person who is immunocompromised, however, even microorganisms that are normally present in the oropharynx can cause an infection. When the microorganisms multiply, they release toxins that induce inflammation in the lung tissue, causing damage to mucus and alveolar membranes. This leads to the development of edema and exudate, which fills the alveoli and reduces the surface area available for exchange of carbon dioxide and oxygen. Some bacteria also cause necrosis of lung tissue. Pneumonia may be confined to one lobe, lobar pneumonia, or be scattered throughout the lungs, bronchopneumonia. Bronchopneumonia occurs more often as HAP or in the very young or old and can be quite serious. Patients may use terms such as walking pneumonia or double pneumonia. These are not medical terms, but it is helpful to understand them. Walking pneumonia refers to a mild infection that may not even keep the patient from working. Or walking, double, is a lay term for bilateral. Etiology: bacterial pneumonia. The most common cause of community-acquired bacterial pneumonias is Streptococcus pneumoniae, also called pneumococcal pneumonia. Other community-acquired infections are caused by Staphylococcus aureus, Chlamydia trachomatis, and Mycoplasma pneumoniae. HAPs are often antibiotic resistant and tend to be much more serious than CAPs. HAPs can be caused by Escherichia coli, Haemophilus influenzae, and Klebsiella pneumoniae, among others. Methicillin-resistant Staphylococcus aureus, MRRS, Pseudomonas aeruginosa, and other antibiotic-resistant pneumonias are especially difficult to treat. Viral pneumonia. Influenza viruses are the most common cause of viral pneumonia. The presence of viral pneumonia increases the patient's susceptibility to a secondary bacterial pneumonia. Generally, patients are less ill with viral pneumonia than with bacterial pneumonia, but they may be ill for a longer period because antibiotics are ineffective against viruses. Fungal pneumonia. Candida and Aspergillus are two types of fungi that can cause pneumonia. Pneumocystis jirovecii pneumonia, PJP, is caused by a fungus and typically causes pneumonia in patients with AIDS. Aspiration pneumonia. Some pneumonias are caused by aspiration of foreign substances, most often in patients with decreased levels of consciousness or impaired cough or gag reflex. These conditions can occur with alcohol ingestion, stroke, general anesthesia, seizures, gastrointestinal reflux disease, GERD, or other serious illness. Aspiration pneumonia increases risk for subsequent bacterial pneumonia. Ventilator-associated pneumonia. VAP is a type of aspiration pneumonia that develops in patients who are intubated and mechanically ventilated. The endotracheal tube keeps the glottis open so secretions can be easily aspirated into the lungs. Chemical pneumonia. Inhalation of toxic chemicals can cause inflammation and tissue damage, which can lead to chemical pneumonia. This increases the risk for subsequent bacterial infection. VAP. Ventilator-associated pneumonia prevention flu, COVID-19, and pneumonia vaccination are essential to preventing pneumonia. All individuals ages 6 months and older should receive the yearly flu vaccine. Check the Centers for Disease Control and Prevention cdc.www.cdc.gov website for flu, COVID-19, and pneumonia vaccine recommendations, which change frequently. See gerontological issues, respiratory infections, and advanced age. Nursing care plays an important role in the prevention of HAP. Regular coughing, deep breathing, and position changes for patients on bed rest or after surgery. Prevention of aspiration for patients at risk, and mouth care and good hand hygiene practices by both patients and healthcare personnel can help prevent many cases. Several health organizations have developed ventilator bundles to prevent VAP in the intensive care unit, ICU. A bundle is a group of interventions that, when used together, can promote quality care. VAP prevention bundles usually include these measures: 1. Elevation of patient's head of bed to 30 to 45 degrees. 2. Daily sedation vacation and daily assessment of readiness for extubation. DV provosis, DVT prophylaxis. Previous VAP bundles have included peptic ulcer prophylaxis, but recent studies have demonstrated that this can actually increase incidence of VAP. Calit, 2019. Calit. Signs and symptoms: patients with pneumonia present with fever, shaking, chills, chest pain, dyspnea, fatigue, and a productive cough. Sputum is purulent or may be rust-colored or blood-tinged. Crackles and wheezes may be heard on lung auscultation because of the exudate in the alveoli and airways. Some bacterial and many viral pneumonias cause atypical symptoms. The patient may experience fatigue, sore throat, dry cough, or nausea and vomiting. Older adult patients may not exhibit expected symptoms of pneumonia. New onset confusion or lethargy in an older patient can indicate reduced oxygenation. This should alert you to look for other symptoms or request evaluation by the healthcare provider, HCP. New onset of fever or dyspnea should also cause suspicion of pneumonia in older adults. Complications from pneumonia most commonly occur in patients with other underlying chronic diseases. Pleurisy and pleural effusion, excess fluid in the pleural space, are two of the most common complications and generally resolve within 1 to 2 weeks. Atelectasis, collapsed alveoli, can occur as a result of trapped secretions. It may be resolved by efforts to keep the airways clear, such as use of an incentive spirometer. Other complications result from spread of infection to other parts of the body, causing septicemia, meningitis, septic arthritis, pericarditis, or endocarditis. Treatment for each of these is antibiotics. Although antibiotics can greatly reduce the incidence of death related to pneumonia, it is still a common cause of death in older people. Diagnostic tests: a chest X-ray examination is done to identify the presence of pulmonary infiltrate, which is fluid leakage into the alveoli from inflammation, Fig. 31.2. In addition, sputum and blood cultures are obtained to identify the organism causing the pneumonia and determine appropriate treatment. If the patient is unable to produce a sputum specimen, a nebulized mist treatment, NMT, may be ordered to promote sputum expectoration. Nasotracheal suctioning or a bronchoscopy can be done to obtain a specimen from a very ill patient. Nursing care tip: obtain sputum culture specimens before antibiotics are started to avoid altering culture results. The best time to obtain a specimen is first thing in the morning, before breakfast. If the patient has eaten, be sure they rinse the mouth to keep food particles out of the specimen. Therapeutic measures: broad-spectrum antibiotics are initiated as soon as cultures are sent to the laboratory, even if results are not completed. Once the culture and sensitivity CNS report is available, antibiotic orders may change to more narrow-spectrum agents. Many patients can be treated with oral antibiotics as outpatients. However, hospitalization and IV therapy may be necessary in older adults or in individuals who are chronically or acutely ill. If the pneumonia is caused by a virus, rest and fluids are recommended. Occasionally, antiviral medications are used. Expectorants, bronchodilators, and analgesics may be given for comfort and symptom relief. NMTs or metered dose inhalers, MDIs, may be used to deliver bronchodilators. Supplemental oxygen via nasal cannula or mask is used as needed. Nursing care is found in nursing care plan for the patient with a lower respiratory tract disorder. See Table 31.1 for a pneumonia summary. Pathophysiology and etiology tuberculosis, TB, is an infectious disease caused by the bacterium Mycobacterium tuberculosis. TB primarily affects the lungs, but the kidneys, liver, brain, and bone may be affected as well. Tuberculosis is an acid-fast bacillus, AFB. When it is stained in the laboratory and then washed with an acid, the stain remains or stays fast. Tuberculosis can live in dark places and dried sputum for months but is killed in a few hours of direct sunlight. It is spread by inhalation of the TB bacilli from respiratory droplets, droplet nuclei, of an infected person. Once the bacilli enter the lungs, they multiply and begin to disseminate to the lymph nodes and then to other parts of the body. The patient is then infected but may or may not go on to develop clinical active disease. TB infection without disease is called latent TB infection. LTBI. The body develops immunity, which keeps the infection under control. If the lungs are involved, the immune system surrounds the infected area in the lung with neutrophils and alveolar macrophages. This creates a lesion called a tubercle that seals off the bacteria and prevents spread. Similar processes take place in other affected areas of the body. The bacteria within the tubercle die or become dormant, and the patient is no longer infectious. If the patient's immune system becomes compromised, however, some of the dormant bacteria can become active, causing disease. Only 5 to 10% of infected people in the United States actually develop the disease. Even then, it may not occur for many years. See gerontological issues, aging and tuberculosis. Risk factors: residents and employees of prisons, nursing homes, homeless shelters, drug treatment facilities, healthcare facilities, and so on have a higher risk for TB exposure and infection. Aging, AIDS, chronic drug or alcohol abuse, and certain medications, for example chemotherapy and some medications for rheumatoid arthritis, Crohn's disease, or psoriasis, can compromise immune function and increase risk of activation. The incidence of TB has been decreasing for the past 2 decades, but progress is now slowing down. The effects of health disparities are apparent, with 88% of TB cases occurring in racial and ethnic minority groups. Prevention: if a hospitalized patient is known or suspected to have TB, they are placed in respiratory isolation to prevent spread to staff or other patients. Special negative pressure isolation rooms are ventilated to the outside. Staff should wear a particulate filter respirator certified by the Centers for Disease Control and Prevention, CDC, and the National Institute for Occupational Safety and Health, NIOSH. When in the room of a patient with TB, a regular surgical mask is not effective against TB. Masks should be fitted to size of the employee's face. If the patient must travel through the hallway for tests or other activities, they must wear a mask. Additional personal protective equipment such as gowns, gloves, or goggles are used when contact with sputum is likely. A vaccine against TB, the Bacillus calmette-guerin (BCG) vaccine, is available. It is used in areas where TB is prevalent. It is not used routinely in the United States because of the low risk for infection. Individuals who have had the vaccine will have a positive skin test for TB, so alternative methods for screening must be used. Ultimately, prevention will come from adequate treatment of patients with TB. A current concern is the development of antibiotic-resistant strains of the TB bacillus, which can develop when patients are non-compliant with medication therapy. When antibiotics are taken intermittently or discontinued early, the more virulent, stronger bacteria survive and multiply, and become resistant to the medications being used. This multi-drug resistant TB, MDR-TB, can then be passed on to someone else. Some strains are resistant to nearly all antibiotics. These strains are called extensively drug-resistant TB, XDR-TB. It is therefore vital to reinforce the importance of strict adherence to medications therapy. Patients who are at risk for non-adherence to medications therapy must have a visiting nurse or other health professional observe each dose of antibiotic taken. This is called directly observed therapy, or DOT. DOT transfers responsibility for making sure the medications are taken from the patient to the healthcare worker. The World Health Organization reports the highest treatment success rates with DOT. Because progress in decreasing TB cases in the United States is slowing down, Healthy People 2030 has developed a goal to reduce the rate of TB by curing people with active TB and expanding testing and treatment for latent TB. Office of Disease Prevention and Health Promotion, 2020. Signs and symptoms. A diagnosis of TB should be suspected when the patient presents with a cough longer than 2 or 3 weeks in duration, pain in the chest, coughing up blood or sputum, night sweats, fevers, weight loss, and/or swollen lymph nodes. As the disease progresses, progressive weight loss and dyspnea may occur. Older adults may present with less specific symptoms such as dyspnea and fatigue. Complications. Spread of the TB bacilli throughout the body can result in pleuritis, pericarditis, meningitis, bone and joint infections, genitourinary or gastrointestinal, GI, infection, and infection of many other organs. Diagnostic tests. Routine screening for TB infection is usually done with a purified protein derivative, PPD, skin test. The PPD is injected intradermally. The test is considered positive if a raised area of induration occurs within 48 to 72 hours. If a red area appears around the induration, this is not measured. The size of induration that indicates a positive test varies based on the individual's history, Table 31.2. Test. If a person is allergic, has limited ability to react to the test due to immune dysfunction, a smaller area of induration would be considered a positive result. A red area without induration is considered a negative result. A positive result indicates that a person has been exposed to TB. It does not mean that active TB disease is present. Some healthcare institutions use a 2-step process for baseline testing of employees and residents. If an individual has a negative PPD test, he or she is retested in 1 to 3 weeks. Someone who was exposed many years ago may not react to the first test, which acts as a reminder to the immune system to react. In this case, the second test will be positive. Nursing care tip. You have probably had a purified protein derivative, PPD, skin test, so you can do your clinical practice for school. When you have it checked, the clinician should touch your arm. Just looking at it is not adequate to judge whether there is a raised area of induration. The quantifier on TB, QFT-TB, and T-spot tests are blood tests that detect the cell-mediated immune response to TB bacteria in blood. Unlike the PPD skin test, these are simple blood tests and are valid in individuals who have been vaccinated against TB. A chest X-ray is used as a screening tool in someone with a positive test. Final diagnosis is made based on sputum culture results. Be safe. Avoid failure to communicate while awaiting culture results on a patient in a facility. Ask the HCP or infection control nurse whether the patient should be isolated to protect staff and other patients. Please see page 543 in your textbook. Therapeutic measures treatment consists of antibiotic therapy. First-line medications have the fewest adverse effects. Isoniazid, rifampicin, ethambutyl, pyrazinamide, however, they can still be toxic to the liver and nervous system and have other side effects. More toxic antibiotics are reserved for cases that do not respond to first-line medication therapy. Generally, 2 or 3 antibiotics are given simultaneously to allow lower doses of each individual medications, reducing the incidence of serious side effects as well as the risk of developing resistant bacteria. Medications must be taken for 6 to 9 months or up to 2 years for MDR-TB. Because of the length of therapy and the incidence of side effects, adherence is often a problem. Additional treatment is supportive. Rest and good nutrition are important for helping the patient's own immune system to work. Patients must be isolated until their sputum no longer contains TB bacteria. Typically, after about 2 weeks on antibiotic therapy, the patient is no longer contagious, but a sputum culture must be done to confirm this. Reinforce to the patient that they avoid being around others and use proper hand hygiene during this time period. Approximately 80% of the TB cases in the United States progress from LTBI. Hence, the CDC now recommends treating patients with LTBI with 3 months of isoniazid plus rifampicin, Sterling et al., 2020. The CDC provides information about TB at www.cdc.gov. Simply type tuberculosis into the search window. Restrictive disorders are those problems that limit the ability of the patient to expand the lungs and inhale air. Restrictive disorders can be intrinsic, involving lung tissue, for example, pulmonary fibrosis, for extrinsic, involving structures outside the lungs, for example, pleural effusion. Pathophysiology recall that the visceral and parietal pleurae are the membranes that surround the lungs. Between these membranes is a small amount of serous fluid that prevents friction as the pleurae slide over each other during inhalation and exhalation. If the membranes become inflamed, they do not slide as easily. Instead of sliding, one membrane may catch on the other, causing it to stretch as the patient attempts to take a breath. This causes a characteristic sharp pain on inspiration. The irritation causes an increase in the formation of pleural fluid to reduce friction and decrease pain. Etiology pleurisy is usually related to another underlying respiratory disorder, such as pneumonia, TB, a tumor, or trauma. Non-respiratory disorders such as pancreatitis or certain autoimmune disorders can also result in pleurisy. Signs and symptoms: pleurisy causes a sharp pain in the chest on inspiration. Pain also occurs during coughing or sneezing. Breathing may be shallow and rapid because deep breathing increases pain. The patient may also exhibit fever, chills, and an elevated white blood cell (WBC) count if the cause is infectious. A pleural friction rub is heard on auscultation. Pathophysiology: when excess fluid collects in the pleural space, it is called a pleural effusion. Fluid normally enters the pleural space from surrounding capillaries and is reabsorbed by the lymphatic system. When a pathological condition causes an increase in fluid production or inadequate reabsorption of fluid, excess fluid collects. A normal amount of pleural fluid around each lung is 1 to 15 ml. More than 25 ml of fluid is considered abnormal. In pleural effusion, as much as several liters of fluid can collect. The effusion can be either transudative, a watery fluid from the capillaries, or exudative, with fluid containing WBCs and protein from an inflammatory or infectious process. Empyema is the collection of pus in the pleural space. It is a pleural effusion that is infected. Empyema is usually a complication of pneumonia, TB, or lung abscess. Symptoms, diagnosis, therapeutic measures, and nursing care are the same as the care of the patient with a pleural effusion, with an added emphasis on identifying and resolving the infection. A chest tube or surgery may be necessary to drain the area. Etiology like pleurisy, pleural effusion, is generally caused by another lung disorder as a symptom, not a disease. Transudative effusion may result from heart failure, liver disorders, or kidney disorders. Exudative effusion more commonly occurs with lung cancer, infection, or inflammation. Signs and symptoms depend on the amount of fluid in the pleural space. The patient may or may not experience pleuritic pain. Increasing shortness of breath occurs because of the decreasing space for lung expansion. Cough and tachypnea may be present. A dull sound is heard when the affected area is percussed. Lung sounds are decreased or absent over the effusion, and a friction rub may be auscultated. Diagnostic tests: a chest X-ray or CT scan is done to determine whether pleural effusion is present. If a thoracentesis is done, fluid samples are sent to the laboratory for CNS and cytological examination. Further tests are done to determine the cause of the effusion. Therapeutic measures: the underlying cause should be treated, for example, diuretics for heart failure patients or antibiotics for bacterial pneumonia. If symptoms are severe, a therapeutic thoracentesis is done to remove the excess fluid from the pleural space and relieve the patient of dyspnea. Chapter 29 discusses how to assist with a thoracentesis. Patients usually experience immediate improvement in dyspnea following thoracentesis. The HCP uses X-ray examinations and percussion, or sometimes ultrasound to determine where to insert the needle to obtain the fluid. If the fluid accumulation is large or recurring, a chest tube may be placed to continuously drain the pleural space. Occasionally, talc or another irritating agent will be instilled via the chest tube to cause pleural membranes to adhere to each other. This is called pleurodesis, eliminating the pleural space and preventing future episodes of pleural effusion. Treatment of the cause of the effusion is necessary to prevent recurrence. Pathophysiology pulmonary fibrosis, PF, sometimes called interstitial lung disease, is a group of disorders that cause scarring and fibrosis of lung tissue. PF may evolve from injury to the alveoli, causing chronic inflammation. Inflamed tissues are gradually replaced by fibrous connective tissue. Alveoli become thick and scarred, and gas exchange becomes difficult. Etiology: various factors are linked with PF, including heredity, exposure to certain viral illnesses, wood and metal dust exposure, medications, radiation therapy, and smoking. It may also be associated with some autoimmune disorders such as lupus erythematosus or rheumatoid arthritis. Chronic GERD may play a role. Often, PF is called idiopathic PF because no specific cause can be found. Signs and symptoms: patients with PF experience progressive shortness of breath. Inspiratory crackles and chronic cough are present. Some experience flu-like symptoms. Fatigue is common and clubbing of fingers may be present. The average patient has a gradual decline in lung function with eventual respiratory failure and death in approximately 4 years. Diagnostic tests: a chest X-ray may show lung infiltrates. A CT scan may be done. Spirometry is done to verify that the condition is restrictive. Arterial blood gases, ABGs, may show reduced partial pressure of oxygen, PAO2.C. A bronchoscopy and lung biopsy can help rule out other causes of the patient's symptoms. They can also show inflammation and fibrosis. A blood test, anti-nuclear antibodies, shows whether an autoimmune process is involved. Therapeutic measures: 2 new antifibrotic medications, pirfenidone, Esbriet, and nintedanib, OVEV, can reduce disease progression and preserve lung function. Patients should be encouraged to stop smoking and to avoid secondhand smoke. Oxygen is used if needed to maintain oxygenation. Patients should receive flu and pneumococcal vaccines. Aerobic and breathing exercise can help decrease dyspnea. Lung transplant may be considered for patients with few comorbidities. Pulmonary rehabilitation helps patients maintain optimum activity tolerance. Atelectasis. Atelectasis is the collapse of alveoli. It most commonly occurs in post-surgical patients who do not cough and deep breathe effectively, but can result from anything that causes hypoventilation. Areas of the lungs that are not well aerated become plugged with mucus, preventing inflation of alveoli. As a result, alveoli collapse. Compression of lung tissue from effusion or a tumor can also cause atelectasis. The focus of nursing care is on prevention. Patients should be taught the importance of coughing and deep breathing, or the use of an incentive spirometer whenever the risk for hypoventilation is present. Frequent position changes and ambulation are also helpful. Obstructive disorders are characterized by air trapping and difficulty getting air out of the lungs. Obstructive disorders covered in this chapter include chronic obstructive pulmonary disease, emphysema, chronic bronchitis, asthma, and cystic fibrosis. Chronic obstructive pulmonary disease / chronic airflow limitation, according to the American Lung Association. 2021, 16.4 million adults in the United States have been diagnosed with chronic obstructive pulmonary disease, COPD. CURL. Many more likely have it, but have not yet been diagnosed. Death rates in men have fallen slightly in recent years, but death rates in women are steady due to more women smoking. Chronic bronchitis and emphysema are the primary underlying disorders in COPD. Asthma also may play a role. Pathophysiology COPD is a group of pulmonary disorders characterized by difficulty exhaling. In COPD, airways are narrowed or blocked by inflammation and mucus, and there is loss of elasticity in the alveoli. Both conditions make it difficult for air to be removed from the alveoli, leading to trapping of air. More effort is required for weakened alveoli to push air out through obstructed airways. Fig. 31.3. Emphysema, chronic bronchitis, and asthma are disorders that limit airflow. A patient with COPD may have some degree of both emphysema and chronic bronchitis. Asthma may also be present, but it differs somewhat because the airway limitation in asthma is usually reversible. A patient with unremitting asthma is treated as having COPD. Airflow limitation in emphysema and bronchitis is progressive and minimally reversible. Fig. 31.4. COPD may also be referred to as chronic airflow limitation, CAL, or chronic obstructive lung disease. COPD develops slowly and may be present for many years before symptoms become evident. It may be advanced by the time the patient seeks treatment. It is characterized by periods of relative stability and exacerbations, which may be triggered by respiratory infection or other stressors. See Table 31.3 for a COPD summary. Chronic bronchitis pathophysiology. Chronic bronchitis is similar to acute bronchitis, with symptoms occurring for at least 3 months of the year for 2 consecutive years. Patients may have multiple exacerbations, each lasting 2 weeks or more. The bronchial tree becomes inflamed from inhaled irritants. Impaired ciliary function reduces the ability to remove the irritants. The mucus-producing glands in the airways become hypertrophied, producing excessive thick tenacious mucus, which obstructs airways and traps air. Fig. 31.5. These changes lead to chronic low-grade infection. Emphysema pathophysiology. Emphysema affects the respiratory bronchioles and alveoli distal to the terminal bronchioles, causing destruction of the alveolar walls and loss of elastic recoil. See Fig. 31.5. This also causes damage to adjacent pulmonary capillaries. Because of the loss of elastic recoil, passive exhalation is impaired and air is trapped in the alveoli. The combination of damaged alveoli and capillaries causes reduced surface area for gas exchange. Etiology: smoking is the single most important risk factor for COPD. Other types of tobacco used in pipes, cigars, or water pipes as well as marijuana are also risk factors. Vaping, e-cigarettes has also been linked to COPD. Other factors include passive, secondhand, indoor and outdoor air pollution and exposure to industrial chemicals, dust, and fumes in the workplace. Studies are ongoing regarding the effects of third-hand smoking, nicotine residue left on indoor surfaces and clothing, but some familial predisposition to chronic bronchitis has been demonstrated. A small number of individuals have an inherited deficiency of the enzyme alpha, 1-antitrypsin AAT, which causes a predisposition to the development of emphysema. Patients with this inherited tendency who also smoke have a very high risk of developing the disease. Children of smoking parents are at higher risk because of smoke exposure. Prevention is important because no cure for COPD is currently available. Avoidance of smoking and other inhaled irritants is vital, especially in individuals with parents or siblings with COPD. Remind your patients that e-cigarettes contain nicotine and are as addictive as other cigarettes. Classic symptoms of COPD are chronic cough, with or without sputum production, and progressive dyspnea on exertion. Patients exhibit prolonged exhalation because of obstructed air passages and reduced elastic recoil. Air trapping causes the lungs to become hyperinflated, which leads to the classic barrel chest. a round, bulging chest that has the shape of a barrel. ABGs may be checked during an acute exacerbation of COPD and show an increase in partial pressure of carbon dioxide, PaCO2, and a low PaO2. The patient develops polycythemia in response to chronic hypoxemia, which results in a ruddy skin color. Cyanosis may also be present. In late stages of COPD, patients may lose weight and become malnourished. They have difficulty eating because of severe dyspnea, and the increased work of breathing expends more calories. Chronic hypoxemia causes a release of chemicals that may also lead to weight loss. Patients use accessory muscles to breathe and tend to assume the classic tripod position to aid breathing. The patient with chronic bronchitis has a chronic productive cough, shortness of breath, and activity intolerance. Symptoms may initially be worse in the winter months. Crackles and wheezing are often noted on auscultation and may improve after coughing. The most characteristic symptom of emphysema is progressive shortness of breath, accompanied by activity intolerance. Use of accessory muscles to breathe is evident. Auscultation reveals diminished breath sounds. Remember that many patients have symptoms of both chronic bronchitis and emphysema. Absolutely no smoking for patients with COPD. Complications: some patients with emphysema develop large air spaces within the lung tissue, bullae, or adjacent to the pleurae, blebs, point we. Similar to blisters, they can rupture and cause the lung to collapse. Right-sided heart failure may develop because the heart has to work harder to pump blood to the diseased lungs. See the section on cor pulmonale in Chapter 26. Death usually results from respiratory infection or respiratory failure. Diagnostic tests information from spirometry is correlated with the history and physical examination to diagnose COPD. Spirometry is essential for diagnosis. Normally, the FEV1 is about 70 to 80% of the FVC. In COPD, the FEV1 following bronchodilator use is less than 70%. The patient with airflow limitation cannot forcefully exhale as much air in the first second as normally expected. If lung function improves after a bronchodilator, asthma is suspected rather than COPD. An AAT level is checked if deficiency is suspected, especially in patients with a family history of COPD. CBC, electrolytes, and sputum culture may be assessed during exacerbations. COPD is classified according to spirometry results into 4 grades, from Gold 1, mild airflow limitation, to Gold 4, very severe airflow limitation, and into 4 categories, A, B, C, D, based on symptoms, Global Initiative for Chronic Obstructive Lung Disease, Gold Mallet 2017. So 1A would be very mild, and 4D would indicate severe disease. Therapeutic measures. The goals of COPD treatment, according to the GOLD guidelines, are to reduce symptoms and reduce risk of exacerbations. GOLD 2021, Hours. In addition, the reduction of exposure to tobacco and occupational exposures should be included as a goal throughout any management program. Oxygen. Oxygen therapy is used in patients with chronic oxygen saturation levels of 88% or less. Oxygen flow rate is titrated, adjusted to achieve oxygen saturation between 88 and 92%. If the patient tends to retain CO2, having a much higher saturation could reduce the respiratory drive. But remember that our brains need oxygen. Always aim for 88 and 92% in patients with COPD and watch your patients closely. If they become drowsy or their respiratory rate falls too low, call the registered nurse, RN, or HCP. Medications. Medications commonly used include adrenergic and anticholinergic MDIs or NMTs to open airways, corticosteroid inhalers to control inflammation, and antibiotics when needed. Antitussive agents should be avoided with COPD because patients must be able to cough up secretions. Oral theophylline bronchodilators are sometimes used but have significant side effects, so are avoided if possible. Oral or IV corticosteroids are used for acute exacerbations. Replacement of AAT may be used in emphysema patients who are deficient. See Table 31.4 for a more detailed list of medications used in the treatment of COPD. Patients with COPD should also be assessed for depression. Depression is common with chronic illness and often goes undiagnosed. Patients may not report feeling depressed, but experience more physical symptoms. Antidepressant medications, if indicated, can increase quality of life for COPD patients. Morphine or other opioids may be effective in reducing acute dyspnea and anxiety. They are reserved for end-stage disease. Supportive care. Pneumococcal and yearly influenza vaccinations are recommended to reduce the risk of respiratory infection. Advise avoidance of crowds and exposure to people with respiratory infections. Good hydration and a cool mist humidifier help keep secretions loose. A dietitian consultation is helpful for the patient who is unable to maintain a desirable weight. Breathing exercises help improve oxygenation and reduce anxiety. See Chapter 29. Surgery. Surgical removal of emphysematous lung tissue, called lung volume reduction surgery, or LVRS, increases the space available for good lung tissue to expand, reducing dyspnea and increasing exercise tolerance. This is a high-risk procedure but has allowed some patients to return to a more normal activity level and improved quality of life. Surgery may also be performed to remove blebs to prevent pneumothorax. Lung transplant may be an option in select patients. ENDOBRONCHIAL valve. A newer treatment is similar to lung reduction surgery but without the surgery. It is placement of a tiny one-way valve called an endobronchial valve via bronchoscopy into an area of emphysematous lung, which causes the diseased area to collapse. This allows the healthy lung tissue more space to expand, which can increase FEV1 and exercise tolerance. Mechanical ventilation. If ABGs worsen despite treatment, intubation and mechanical ventilation may be considered depending on the patient's advanced directive. Unfortunately, mechanical ventilation will not make a patient's disease better, and weaning may be difficult or impossible once it is initiated. Use of NIPPV, see Chapter 29, may be a good alternative for many patients. END off life planning. It is important to assess whether the patient has a living will or durable power of attorney for healthcare. See Chapter 17.3. COPD is a progressive disease, and patients can increase the quality of their life and death by making decisions in advance. Patients should make decisions about whether they would want to be intubated and mechanically ventilated, or have cardiopulmonary resuscitation, CPR, in event of a cardiac arrest. CPR is rarely successful in a patient with end-stage disease. Patients should be made aware of palliative care and hospice options, and assured that they will be kept as comfortable as possible. Smoking cessation. Even late in the disease process, stopping smoking can slow disease progression and prolong life. Exposure to other respiratory contaminants should also be minimized. Hairspray, other household aerosols, and body powder should be avoided. Fig. 31.6 shows the benefits of smoking cessation. Patient Perspective provides a personal account from one woman who understood too late the importance of smoking cessation. See Chapter 29 for more information. Rehabilitation. Pulmonary rehabilitation programs can help patients increase exercise tolerance and maintain a sense of well-being. Fig. 31.7. Patients exercise in a monitored environment and benefit from the support of other patients with similar problems. Some groups of pulmonary rehabilitation patients have even formed harmonica clubs. Playing their harmonicas mimics pursed lip breathing and may strengthen the diaphragm, the major muscle of breathing. Asthma affects more than 260 million people worldwide. Global Initiative for Asthma GINA, 2021, and 25 million in the United States. Asthma and Allergy Foundation of America, AAFA, 2021. Rates of asthma are highest among Black individuals, who are 3 times more likely to die from asthma than white people. These disparities are related to social determinants of health such as poverty, city air quality, indoor allergens, health literacy, and poor healthcare, AAFA, 2021. With careful monitoring, education, and treatment, however, patients with asthma can manage their symptoms and lead normal lives. Pathophysiology asthma is characterized by chronic inflammation of the airways and hyperresponsiveness of the bronchial smooth muscles, bronchospasm, VOF. This causes narrowed airways and air trapping, which is why it is considered an obstructive disorder. Inflammation occurs in part because things that trigger asthma triggers, cause the release of inflammatory substances such as histamine and leukotrienes. Symptoms are intermittent and generally reversible, with periods of normal airway function. Some people develop permanent changes in their airways, called remodeling. This leads to a progressive loss of lung function. Many patients develop the disorder in childhood, and some outgrow it. However, a significant number develop symptoms again later in life. Children with asthma should be counseled that smoking can increase the risk of recurrence in adulthood. Asthma may also complicate chronic bronchitis or emphysema. Asthma is classified as mild, moderate, or severe based on the amount and type of medication required to control it. GINA, 2021-21. Etiology: the tendency to develop asthma is inherited. The most common predisposing factor is the genetic tendency to be allergic to airborne allergens such as pollen or mold. Viral respiratory infections are also a contributing factor to asthma diagnosis and exacerbation. Tobacco smoke, air pollution, early use of antibiotics, and sensitization to house dust, mites, and cockroaches have also been linked to asthma development. Asthma triggers once asthma develops. Exposure to allergens such as dust mites, cockroaches, cat and dog dander, or pollen can trigger an acute attack. Other possible triggers include viral infection, emotional upset, exercise, stress, and certain medications, for example, aspirin, beta blockers, aspirin. Prevention: although asthma cannot be prevented at this time, research is ongoing to determine factors associated with its development. Current research recommendations include 1. Avoidance of environmental tobacco smoke during pregnancy and a child's first year of life. 2. Vaginal delivery. Exposing baby to mother's vaginal flora may be beneficial. And 3. Avoidance of acetaminophen and broad-spectrum antibiotics during the first year of life. There is increasing evidence for the support of a healthy diet during pregnancy to provide some protection against asthma in children. Appropriate control of childhood asthma may prevent more serious asthma in later years. Avoidance of smoking may reduce the risk of recurrence of asthma that started in childhood. To prevent acute attacks, it is important that the patient identify triggers of asthma symptoms and avoid them whenever possible. Monitoring of symptoms and compliance with prophylactic and maintenance therapy is also important. An asthma plan should be provided to the patient showing the steps required to keep asthma from getting worse, as well as guidance for when to call the HCP or go into the emergency room. Signs and symptoms: asthma symptoms are intermittent and are often referred to as attacks. Attacks may last from minutes to days. Patients report wheezing, chest tightness, dyspnea, coughing, and difficulty moving air in and out of the lungs. Symptoms are often worse at night. Some patients experience coughing but no wheezing. Once initial symptoms are controlled, airways may remain hypersensitive and prone to asthma symptoms for many weeks. On examination, you will note an increased respiratory rate as the patient attempts to compensate for narrowed airways. Inspiratory and expiratory wheezing is heard because of turbulent airflow through swollen airways with thick secretions. Wheezing may sometimes be audible even without a stethoscope. Air is trapped in the lungs, and expiration is prolonged. A cough is common and may produce thick, clear sputum. Use of accessory muscles to breathe is a sign that the attack is severe and warrants immediate attention. Be aware that an absence of audible wheezing may not signal open airways but rather may be an ominous sign that the patient is not moving enough air to make any sound. If wheezing is not heard, use of accessory muscles and peak expiratory flow rate (PEFR) values must be carefully evaluated. Once treatment begins to open the airways, wheezing may become audible. Complication status asthmaticus occurs if bronchospasm is not controlled and symptoms are prolonged. As the patient increases the respiratory rate to compensate for narrowed airways, carbon dioxide is exhaled and respiratory alkalosis occurs. If the attack is not resolved and the patient begins to tire, the patient will no longer be able to compensate. PaCO2 will rise, resulting in respiratory acidosis. This can lead to respiratory failure and death if untreated. Diagnostic test diagnosis is based on the patient's report of symptoms, physical examination, and spirometry results. PEFR and FEV1 are reduced, especially during symptomatic periods. Asthma can be differentiated from COPD during spirometry testing by administering an adrenergic agonist, such as an albuterol inhaler, and then retesting. Asthma symptoms can generally be reversed with the medication, but COPD cannot. Allergy skin testing and increased serum immunoglobulin E and eosinophil levels indicate allergic involvement and may help determine appropriate treatment. ABGs may be evaluated during an acute severe attack. On a long-term basis, asthma control can be evaluated using FEV1 or PEFR measurements, frequency and severity of exacerbations and nighttime awakenings, and frequency of short-acting beta agonist use. Therapeutic measures: patients must learn to manage asthma at home. If they can monitor and manage their symptoms, acute episodes and hospitalizations can be avoided. Self-monitoring. All patients benefit from learning to monitor asthma and make treatment decisions accordingly. This can be done by carefully monitoring symptoms or by monitoring of the peak expiratory flow rate, or PEFR, Fig. 31.8. PEFR is a measurement in liters per minute of the amount of air a patient can blow into a peak flow meter from fully inflated lungs. The patient determines his or her baseline PEFR during symptom-free times. Readings can be charted to keep track of progress. Fig. 31.9. If symptoms worsen or PEFR begins to fall below the patient's baseline, the patient should begin self-treatment according to an asthma action plan. Fig. 31.10. If treatment does not improve PEFR to the expected degree, the patient is advised to go to the emergency department. PEFR results may indicate the onset of asthma before the patient experiences any obvious symptoms. Physical activity as well as breathing exercises have been shown to be beneficial for symptom management and improving the quality of life in patients with asthma. Avoidance of triggers. The patient is instructed to identify and avoid asthma triggers. If triggers cannot be avoided, the patient can use a bronchodilator as prescribed before exposure. Inhalers can be especially useful before exercise. Animal dander and foods that cause symptoms are best avoided when possible. Eliminating carpets and curtains in bedrooms, using vinyl mattress and pillow covers, and installing a portable or central air filter can reduce dust mite exposure. Maintenance of indoor humidity between 40 and 50% can reduce mold growth. If cold air triggers symptoms, the patient should keep the nose and mouth covered when outside in cold weather. Smoking and exposure to secondhand smoke are strongly discouraged. Aspirin and NSAIDs can cause asthma symptoms in some individuals. Beta-blocking medications, for example, propranolol, metoprolol, used commonly for hypertension, block beta receptors in the lungs, preventing the sympathetic nervous system from promoting bronchodilation. These medications should be avoided if they make symptoms worse. Medications. Using short-acting bronchodilators alone is no longer recommended for adults and adolescents. Inhaled corticosteroids such as fluticasone, Flavin, or budesonide, Pulmicort are generally given to control inflammation. Instruct the patient that corticosteroids must be used regularly to prevent symptoms and that they do not provide immediate symptom relief during an acute attack. Long-acting beta-agonist LABA bronchodilators such as salmeterol, Serevent, or formoterol, Foradil, can also help prevent symptoms by keeping airways dilated for up to 12 hours or more. They should be used in combination with inhaled corticosteroids, fluticasone, and salmeterol Advair, budesonide and formoterol, Symbicort, if inhaled medications do not control symptoms, or if the patient has nocturnal symptoms, oral anti-leukotrienes may be added. Immunotherapy, allergy shots may be used for some patients with allergic asthma. An acute asthma attack may be treated with an inhaler, MDI or NMT, or short-acting beta agonists, SABA, IV. Oral corticosteroids, for example, methylprednisolone, prednisone, are potent anti-inflammatory agents that are useful in an acute episode, but because of side effects, they should be avoided for long-term use. Long-term corticosteroids must be tapered before discontinuing to prevent withdrawal symptoms. See discussion of adrenal crisis in Chapter 39. It is important for patients to understand the difference between long-acting maintenance medications and rescue medications and use them appropriately. Oxygen is generally not necessary because many patients hyperventilate during an acute attack. If the attack is prolonged and the patient becomes cyanotic or PaO2 levels begin to fall, oxygen therapy will be used. Cystic fibrosis in the past. Cystic fibrosis, CF, was considered a childhood disease because most affected children did not survive past puberty. However, with new treatments, patients with CF are living longer and more productive lives. Some CF patients now live into their 60s. Pathophysiology CF is a disorder of the exocrine glands that affects the lungs, GI tract, and sweat glands. Abnormal sodium and chloride transport across cell membranes, causing thick, tenacious secretions that cause many of the characteristic symptoms. These sticky respiratory secretions are difficult to remove and cause airway obstruction, trapping air and causing frequent infections. Similar abnormalities in the pancreas cause blocked ducts and retained digestive enzymes. These retained enzymes digest and destroy the exocrine pancreas. The absence of digestive enzymes in the intestines causes malabsorption of essential nutrients, frequent foul-smelling fatty stools, and excess flatus. Patients with CF secrete sweat that is high in sodium and chloride because these electrolytes are not reabsorbed as they pass through the sweat ducts. Etiology CF is a genetic disorder. Both parents must be carriers of the defective gene for CF to present in a child. Patients with CF who marry are counseled on the risk of offspring having the disease. Signs and symptoms usually first appear in infancy or childhood, although a few individuals are not diagnosed until adulthood. Respiratory symptoms are often the first visible manifestation of the disease and range from chronic sinusitis to production of thick, tenacious sputum. Finger clubbing is common. Over time, bouts of infection become more frequent, with eventual loss of lung function and respiratory failure. Frequent foul-smelling stools, poor appetite, bowel obstruction, cirrhosis, cholecystitis, and cholelithiasis are associated findings. Chronic disease causes delayed sexual maturation in both males and females, and infertility is common. Death is usually the result of pulmonary complications, especially antibiotic-resistant infection. Diagnostic tests begin with genetic testing. A blood test for immunoreactive trypsinogen may show high levels in CF. A sweat chloride test determines whether sweat is high in sodium and chloride. You may recall public health campaigns that advise parents to kiss their babies and report any salty taste to their HCPs. Chest X-ray, spirometry, and GI tests also may be done. Therapeutic measures because there is no cure for CF. Treatment is aimed at controlling infection and relieving symptoms. Removal of thick sputum is promoted with hydration, use of a vibratory positive expiratory pressure (PEP) device, CPT, or a high-frequency chest wall oscillation vest. See Chapter 29.7. All forms of smoke should be avoided. NMTs using normal or hypertonic saline or mucolytic medications may be used before CPT. An inhaled medication called Dornis alpha pulmozyme besh is an enzyme that breaks up and loosens mucus. It has been shown to reduce lung infections and improve lung function. Bronchitol, mentioned earlier in the section on bronchiectasis, has been approved for use in adults with CF. Inhaled beta-agonist bronchodilators help keep airways open. Ivacaftor Kalydeco was approved in 2020 for use in patients as young as 4 months. It is the first medication that targets the underlying cause of CF by improving the function of a protein that is defective in patients with CF. Lung transplant is a potentially promising treatment. Pulmonary rehabilitation programs help patients maintain activity tolerance. Patients should receive a yearly flu vaccination. Antibiotics must be administered as soon as signs of infection occur. Antibiotic-resistant infections are a deadly threat to the patient with CF. Patients must be vigilant in avoiding others with infections. Pancreatic enzyme replacement. Pancreasani VOK symptoms reduce symptoms related to malabsorption and improve nutritional status. An increase in calorie requirements necessitates a high-calorie, nutrient-dense diet. For more information, visit the Cystic Fibrosis Foundation at www.cff.org. Nursing process for the patient with cystic fibrosis. See nursing process for the patient with an obstructive disorder. Ineffective airway clearance is the priority nursing diagnosis. Also, be sure to remember the special needs of the adolescent patient with this chronic, debilitating disease. Not only are normal physical growth and development delayed, but psychosocial development is also affected by repeated hospitalizations and the necessity of routine daily medication and treatments. Pathophysiology and embolism is a foreign object that travels through the bloodstream. It may be a blood clot, air, or fat. A pulmonary embolism, sometimes called a pulmonary thromboembolism, PTE, is usually a blood clot that has traveled into a pulmonary artery, Fig. 31.11. Resulting obstruction of blood flow causes a ventilation-perfusion mismatch. In this case, it means that an area of the lung is well ventilated with air but has